Thank you very much, Raymond, Mawaziri, Afia, and Interior, Ndii, my good friend, DSS, Director General, CEO, all protocols observed. I am very privileged today. I have never been in a room with so many Kiraunis. So it's a first for me. It's a first for me I address many groups. I think I would like to get a very good photograph of this particular one. It is not my usual audience. Usually we see you, out there where you are exercising statecraft, and we are sitting down. So to be here addressing you is, I think, quite a momentous occasion and a very important occasion. My task is actually quite simple, because you being mashinani people, I think it is very easy for you to connect with why universal healthcare and access to health is important in the lives of people, as exemplified by the story that CS Deborah just told. So mine is really, I've been asked, I was tasked to connect the dots with our broader bottom-up economic transformation agenda. Why is health sitting there in our 5 pillars? We know health is important, but we don't think of it as economic. We think of it as social, perhaps. So why health sits among those economic pillars like agriculture and micro-enterprises and digital transformation and housing may at first look odd. But once I explain why it's sitting there, I think it will just emphasize and re-emphasize why it is so important, and that this is probably one of the most transformational and consequent initiatives that this administration will do, and potential legacy for President William Ruto for Kenya. So I will begin also with a bit of a story, but not quite a story. Kenya, there's a paradox. Our country is a bit of a paradox. When you look at our country, it looks very developed relative to relative speaking, to our neighbors and African countries. We are seen as one of Africa, a very sort of leading economies. We look very developed if you're in Nairobi. If you look at some of our statistics and parameters, investments, all sorts of things, it looks very developed. And physically, if you look at just visually, it really looks like an upper middle income country if you compare with many other countries. We also do not have the history of some of the challenges that many of our African countries have had. We haven't had political upheaval, conflict, coups. Yeah, so we've been a relatively peaceful country since independence, and we look relatively developed. But when you look at the real development outcomes objectively, when you go to objective development outcomes, even within Africa, we are in the bottom half of real development outcomes. We have a very high incidence of poverty, which has been stuck at around 40%. Yet you see countries with much lower growth, much less human capital and all the other things, much better. I'll give an example. A country like, let's talk about basic things like food security. If you go and check food security statistics around the world, we are bottom 20% in terms of food security, or rather we are one of the most food insecure countries, even in Africa. If you look at a country like Ghana, which has had coups, conflicts, all sorts of things, I think the population that is food insecure is less than 5%. In Kenya, 1 out of 5 Kenyans, 20% of the population, is chronically undernourished. Yeah? It's not a good statistic, particularly when you look at children. We hear a lot about economic growth all the time, but this growth does not seem to translate to prosperity for the majority. So there's a paradox there. A country which appears and has all the visible sort of, you can see the form of what you might call development, but you don't see the substance of it. So where is the disconnect between the form that you see and the substance? That story now connects me with President William Ruto. About 3 years ago, or 3.5 years ago, I had never met him. We had reached out, we had talked on the phone a couple of times, but I had never met him until 3 years ago, even though we had the same kind of political circles. And he was obviously going to run for president. So we sort of reached out to me and we had a conversation. And one of the first things he said in that conversation, and he reached out to me, is to say something. I think he said, you know, I have now accepted that there is something wrong with our economic model. Because we keep doing these things, we keep doing these development things as Jubilee. During Kibaki, we did many things. We thought we had transforming the country. Under Jubilee, we have done this, we have done all manner of things, build infrastructure. We thought we have been transforming the country, but we don't seem to have moved. Yeah? So, why is it that you have so much activity around development, but it is not translating to substantive change that among the people? Why is it that we've done so much, we've done invested, we've done harambes for hospitals, we built level 5, level 6 hospitals, but when I look at my phone, it is full of harambes for medical bills, or people sort of huge amount of distress, despite us doing all this development, among other things, the questions, issues I've said about food security. So that conversation went on, and then sort of it continues today, saying yes, there is something fundamentally wrong with our economic model. And that thing is called trickle-down economics. Trickle-down economics is an ideology that believes that prosperity is created at the top by a few people, and then it trickles down to the masses. Where did we get that ideology? We got that ideology from our colonial legacy. Because if you think about Kenya, our colonial state, and particularly as a settler colony, unlike other countries like Tanzania and others which are protectorates or an indirect rule, if you think about a settler colony, what the settlers did, the colonial did here, it came and created an enclave society around the settler economy. Yeah? An enclave around the settler economy which essentially was to serve the settlers. Those of you out there in the countryside can begin to relate to what I'm saying. And so the people in that enclave economy, society, are those people associated with the state and the settler economy. Yeah? So if you are working in the administration like yourselves, or if the few people who are educated and you are required as a clerk, or something like that. Yeah? So you end up with a system which is like almost like a closed system for a few, and it leaves everybody else behind. Yeah? And if you look at all our institutions, that is the legacy of our institutions. These institutions are designed around a formal economy and structure. That's where it looks developed. But most of the people, the pastoralists and the fisher folk and all other people out there are not part of it. Yeah? So, what has happened over time, you start with that system. You have, at independence, a population of only 6 million people. It includes maybe only 1 million people are in that system. 5 million are out there as smallholder farmers and pastoralists and fisher folk. And 5 billion people can support themselves reasonably with the resources, land and other resources that are available. But when you get to 60 million people, it is very difficult to, that system cannot accommodate that many people, but it's very difficult to exclude 50 million people. And also the resources out there are not sufficient to support 50 million people. And at any rate, because of education and healthcare interventions, those people do not have expectations that they will remain pastoralists and smallholder farmers and fisher folk forever. Yet, the structure you have at the top isn't built to accommodate that many people. So you find that today, and I want to make this connection, we have a workforce of about 19 million people, and the economy we call private sector in Kenya. Yeah? The economy we call private sector, what I'm calling trickle down, only employs 2 million people. The public sector employs another 1 million. So that's 3 million, 3.5 million people. Those 3.5 million people, that leaves how many people? 16 million people. Who are those? They are uko mashinani, smallholder farmers, jua kali, informal sector, in the micro and small enterprise sector. Now, our system is not designed, institutions are not designed to include those people. So let's take health. If you look at the health system that we inherited, it assumed that all those people would be catered for by public hospitals, dispensaries, and health centers out there. And then we created a health insurance only for employed people. So the NHIF was created primarily for people, because if you look at the way it is funded from payroll deductions. So if you are not on a payroll, you are considered, you are outside the system. You don't need health insurance. Yours is to go to the dispensary for small infectious diseases. But if you have critical illness, you are on your own. Yeah? So that was then when you had maybe 300,000 people in the formal wage employment when it was created. But over time, now you have a population and it has grown. So you find that you have then a healthcare system, if you come to Nairobi, where you have world-class healthcare in private hospitals. In fact, these are hospitals actually serve even the elites from the rest of the region. Yeah? That is where leaders from the rest of the region are evacuated. It serves international. It's good enough for the UN people who work here and all of that. But the ordinary Kenyan has a little dispensary, uko, which hardly has drugs. They have to go there if they have just a small infectious disease, sit on a form, queue, go around, spend the entire morning, in which they sort of wasting their productivity, trying to get treatment for a simple infection or something like that. So you find that even when we try to include people, and that's one of the conversations we're having with William Ruto, is how he had tried to enroll people into the NHIF. But the problem is, because they are not on payroll, these people, NHF then created a product for them called voluntary members. Where you pay 500 shillings per month. But a person who's not on payroll cannot remember to constantly be paying their 500 shillings. So they join, and after 2 months, they lapse. Then somebody gets sick and they remember, oh, I should have kept my NHIF current. So they have to wait, pay, and then now they try and access healthcare. What that causes is a problem where now the only people who are enrolled are the people who are sick. Because we call that in health economics adverse selection. So that you're only joining, yet an insurance is supposed to ensure everybody pulls money so that the actual cost, whatever is low, it doesn't work. It is not fit for purpose. So you find the same. Think about Social Security, NSSF. It is only for people who are payroll. If you are out there, you are a mechanic in this country, even if you have a high income, there's no mechanism for you to easily save for retirement. The consequence of that is that you have then ended up with something, a very high, what do you call, a crisis of catastrophic health expenditure shocks. According to a study carried not too long ago, I think the data is about 2018 when you had research, it showed 1 million Kenyans in that year when that survey was carried fall into poverty because of a health shock. Somebody gets sick, okay, and when they get sick, then the household, because they don't have health insurance and they are not employed, so if you are an employee like yourselves, if somebody gets sick, even if it's yourself or somebody, one, you have a health cover, two, you get leave, you get sick leave, and you continue, and so you're covered in terms of health care, and you are on sick leave, so you are getting an income. Now, if you are self-employed, if you are in Juakali out there, self-employed as a Kenyan, what happens? One, you can't work. Yeah? Because nobody gives you leave from your kiosk. True? There's no leave from your kiosk, so you close your kiosk or whatever small business you are doing. Then you need to pay for health. So you take the money which was running the business. You take the working capital and it is consumed by illness. So 1 million Kenyans every year fall into poverty because of a health shock in the family. That's about 250,000 households out of a total of 12.5 million households. So Kenya, poverty cannot go down. If you have 85% of your workforce is self-employed and they are exposed to health shocks, yeah, it means that the health shock not only affects your health, it actually is financially catastrophic for that particular household. And if it is financially catastrophic, that is why even those businesses will not go. And that's why we get stuck. We get stuck treading water. Because people are trying to get in the health. So you are progressing, kidogo, you get sick. Or somebody gets sick. Then you sell the cow. Yeah? Once you sell the cow, you're back to, yeah. So, health expenditures, health shocks, is one of the biggest causes. Actually, it is the biggest, not one of the biggest. It's actually established. It is the biggest cause of business failure. It is the biggest cause of people falling into poverty, and it is the biggest cause of keeping poor people poor. And this is the scientific. Let's give you an example. Think about Nyanza and Western Lake region. Now, Lake region has very good land. It has high rainfall. Yeah, it has all the, for an agricultural country, it has high agricultural potential. Why does it have very high incidence of poverty? One thing only. Who can guess what it is? Why does the Lake region have a high incidence of poverty despite what is visibly a high agricultural potential? One thing only, even within ill health. Somebody is whispering the right thing. Malaria. High incidence of malaria. What does malaria do? One, you know about malaria is very high incidence. If you go there, you will find every other household has somebody who has malaria. True? Now, if somebody has malaria, they cannot work. Okay? Now, if that's a sort of bread earner, they are not working. You see, they are not given sick leave from their shop or from the farm. Okay? If it is planting season, you don't have the income even to buy inputs. Okay? Then that person probably needs somebody to care for them. So another person is the household workforce to take care of the sick person. Okay? You are taking, what does agriculture need? Labor. It needs labor. And so the resources of the household that are also needed for inputs and whatever. So that region suffers from a malaria poverty trap. Again, healthcare. So we sat down, as I said, and as we were discussing and narrowing down the things we needed to do with William Ruto, president, then he was candidate, health became very important. We said, then we must be able to take on this beast called health and make sure that everybody, and when you do the math, the statistics bear you out. These people will tell you, if you look at our total health expenditure, we spent, the last time, I think the last data we have, which is about 2 years ago, 150 billion shillings out of pocket health expenditure. Yeah? And that incidence, it not only affects those people who are at the bottom, as we are talking about, because even people who are not every so often, because we are families, we have extended families, they are also being financed by other people. So it is taking money out of businesses, out of, when we were talking to the cooperatives last week about this and providing finance for universal health care, for the onboarding people into shift, the cooperatives told us, SACCOs, in fact, we have been talking about this for a very long time. And we were even considered how we can start our own health insurance for SACCOs. Why did SACCOs think that they should consider starting health insurance? Can you guess? But why would SACCOs, why would that problem become so visible to SACCOs? Actually, the answer is the biggest reason for people liquidating their SACCO savings, yeah, or defaulting on their loans is health shocks. So somebody has put money in their SACCO, whatever, and they come and say, look, I need to cash out my SACCO. Why? Or my mom is sick, we need to take her to India. So we are whatever in the family, and the only money I have is the money in the SACCO. So SACCO begin asking, what can we do to? Because why else would there is other reasons you could persevere and say that keep savings. But if it is your own health or the health of your loved one, a spouse, a child, a parent, then I think that is a no choice situation. So you have sold one has sold the cow, you liquidate your SACCO, you sell the car, you can always buy that one later and deal with the health situation. So it's all around us. You can see the connection between, so even if we are trying to support agriculture, yeah, health shocks are pulling us down. You are trying to support small businesses, health shocks are pulling us down. Yet, the infrastructure we have, the only thing it can provide for people who are not on payroll, because it is a legacy system of that colonial structure I talk about, it could come up with was, we cannot determine these people's incomes, we don't know what they earn, so let's put a flat 500 bob. So whether somebody is a Juakali mechanic or a rich businessman, all of you pay 500 shillings. So it is actually not, and that's because the system. So what we sat down, and we sat for a long time, is to try and figure out how can we design a system which is designed for our society as is. Not one which we are inheriting and just copy and paste from Western countries where everybody is employed by a big company, by a big organization. Because we are an economy of self-employed people. So we have to design a system which works for us. Not copy one, which we have tried to plug it in, plug it, people patch it up. In the end, we said, you know what, let us just put this thing there and start from scratch. So we sat down with Dr. Amoth here and other people and started thinking, how do we actually design? And perhaps this is the journey we should have started many, many years ago, saying how do we design institutions and structures and economic system which works for our economy the way it is. Not one which picks a few people and says the ones who are in suits and whatever and design and just copy and paste the Western systems which can fit those people. Alafu hao wengine, the rest of the Kenyans who go fishing, hao watajipanga. Yeah, their lives are too complicated. You try and fit them in this system, their lives are too complicated. One of the things which is really helping us to do that is digital. Because digital technologies now allow us to reach people, to connect people irrespective of where they are. Many of you remember, some of you, no, maybe not many, not as many. Sometimes we forget, some of us now are no longer vijana. And we are on the other side of whatever. But would remember when banking was only for the elite. For you to have a bank account, You are a very important person in society. Yeah? The ordinary people, they dealt with cash. Many of you remember when only senior officers in government or private sector had a telephone in the house. In fact, it used to be one or two people in the whole community, and the people who needed to make calls had to come and queue there to the person who owns a telephone. What digital technology has done is universalize these technologies. And now they enable us to leverage on this kind of technology so that you officers can onboard 6 million farmers onto a digital platform and enable us to deliver that fertilizer subsidy at the touch of a button. So he said, even in health, what enables us to now be able to universalize our healthcare system is to use leverage on that digital technology. Because digital technology does not discriminate whether you are informal, whether you are a pastoralist, whether you are, it doesn't discriminate. You are now able to connect the connectivity with every Kenyan. You do not need to be in a formal institution for us to be able to plan and whatever. And we've already started in the healthcare. I think many of you will have interacted with the community health promoters. We have built that digital platform. It is now possible for this doctor sitting here to tell you today how many people have been visited by CHPs. They have taken their blood pressure and their blood sugar, and how many people have been referred for further investigation, potentially for diabetes or high blood pressure or hypertension. Now, that capability means that person, that old person who has, that parent or whoever, who has been investigated and for diabetes, that is probably a kidney disease averted. That person who has been investigated and referred for hypertension, it is heart disease averted. It's a heart disease averted. So with that capability then enable us to bring the quality of health care, world-class quality of health care to that person. In fact, probably better than many other places, including developed countries in the world. It allows us to begin to close that gap. So that is the opportunity, and not only opportunity, but imperative. Why this is so important? It is so important because in terms of healthcare cost, if you can avert that case of that person, and now we are moving to a case where society is also aging, so that you are shifting to about moving from a burden of infectious diseases to what these people here call non-communicable diseases. And once you move to non-communicable diseases, the kidney, the heart, the kidneys, all those cancers, the burden of catastrophic expenditures become even heavier. Very heavier. So it is very important that we take this action now. And we put everybody in one pool, one insured system, one provision system, because that burden, when that burden happens and that person needs to go to India and they need 5 million shillings, all of us have to put that money. And that money is we are taking out of other economic activity. The disease burden and the financial cost of that disease burden might actually overwhelm us economically. So we are not going to make economic progress until we solve our healthcare financing problem, healthcare financing challenge. That is the message. So people are going to ask lots of questions. Why do we have to pay more for this social health insurance, where we can get social health insurance, private health insurance somewhere else? That is the problem we have had in this country, where we have a small group of people who are able to provide for themselves in that enclave that I talked about of a small privileged economy. You think you have left everybody else behind. You think it is not your problem. But in fact, what it does is that it drags all of us down. It is keeping us down because you cannot leave behind 55 million people. You cannot have a prosperous economy. You cannot transform this economy and society by having only 2 million or 3 million people in the formal economy with institutions designed around those people living behind the other 55 million Kenyans. I think that's the message that I hope we can be able to convey to everyone so that we understand that we cannot leave anyone behind. It is counterproductive. It is defeatist. That is why we look developed, but we are not developed. So thank you very much for listening to me.
Let's give Prof.